Well, here at this meeting, they released an update to the prevention guidelines of the ESC. There's added emphasis, I think, in them on the global health implications of making sure that we follow through in prevention. Risk stratification is key, I think, in primary prevention to identify people for initial treatment with statins. Related to that, I actually have some data presenting here on under treatment, unfortunately, a US real-world database where a lot of people with known disease are not on statins and then not at goal. So room to move in terms of implementing these guidelines. The ESC kept targets. In the United States, that became a hot topic that fortunately got fixed with the ACC document in 2016. So for higher risk atherosclerotic disease patients, having a target of getting below 70 milligrams per deciliter or 1.8 millimoles is retained in the ESC guidelines, and then 100 for primary prevention. And that's a pretty simple thing to implement in the office, and certainly something that I talk about with my patients, of trying to get below 100 for primary prevention and less than 70. And even amongst the patients with known disease, the highest risk patients, a recent MI patient, based on Improve It, targeting more towards 50 is in my practice and some other physicians as well. Unfortunately, every registry that we do, we find that when looking at all the metrics, be it in blood pressure or cholesterol management, that it's not really matching what we would expect. Some of that, I think, will be data capture in registries, but a lot of it can also be patient compliance of not fully understanding how important this is, and that is a point of emphasis in current guidelines, is making sure that we communicate well with the patients to help them in adherence. But trying to implement the therapies that we know. We have statins, then high-dose statins, add-on therapy with ezetimibe, and then in some cases PCSK9. So a lot of therapies that we can use to intensify treatment, but we seem to get a little bit stuck with the 2013 guideline on just use the statin. That's where the evidence base is. But we do have evidence to support further pushing down the LDL with non-statin therapies. And so that really, I would say, is the current need, is for us to relook at, are we really optimally managing our patients? The ACC-AHA guideline in the US, the full guideline was done in 2013. It was a radical departure, an attempt to be very evidence-based, and so they implemented that very strictly, and so only included things that had very strong evidence base. Unfortunately, for guidelines, there are a lot of things that we don't have all the evidence we would want. Subsequent to that, we had the Improve It trial that was non-statin therapy that was beneficial, and so that's where the 2016 update, just by the ACC, so not a full guideline update, but an adjunct document, was helpful. The ESC has always kept a good focus on all of the levels of evidence and types of evidence, and so there hasn't been that much of a shift initially away from and back towards, and so they've retained targets. I think that is appropriate. Well, with electronic health records, we do have access to a lot of real-world data in very large numbers. And this can be very helpful for us to look carefully at what we're actually doing. I'm reminded of a patient from 10 or 15 years ago who had worsening angina. I looked and they weren't on a beta blocker with known coronary disease, and I was like, how could I have seen this patient? And they were stable, and you know, sometimes we forget things, or people are stable on their current regimen, we don't intensify therapy. So it's very common, even for myself, to not sit down and say, run a checklist of everything that a person should be getting. And so that's where the real world data on a macro scale can help us see, gee whiz, there are gaps relative to what we should be doing. And then to try and implement that patient by patient in our practice, is a way that we can offer all the benefits that have been seen over the last 10, 20 years in cardiovascular medicine. So exciting new tool really for us to look carefully and then try and change what we're doing. Well, out of these meetings, I think there are useful data, and emphasis on prevention is certainly an important area with such a global impact that almost every patient has a need for cardiovascular prevention and risk stratification. And so trying to take that to each patient that we see is an important message. And using all the tools that we've seen in the trials, in our individual patients is key. Ongoing discussion with patients and including them in their understanding of the disease process and what the medications are trying to do, I think is a key component on the adherence part of that. If they understand what we're trying to do for their benefit, that really helps it be a partnership in improving their outcomes.